Hi, Andrew Wolf here. In this video I'm going to talk about the concentration of urine. This is actually my third iteration of this video. It's a fairly complicated concept, but I'm really working on making it simple enough for you to visualize. So I believe the third time will be a charm, and I've got a good way to describe this in a way that you can understand it. So we have here at the beginning of the story with the kidney, and the formation of urine always starts here at the glomerulus. So we have the afferent arteriole bringing blood to the glomerulus, and then the efferent arteriole bringing the blood away, and then we have the formation of filtrate that comes in here. Now, if you've watched my video on tubular reabsorption and secretion, then you know that here in the proximal tubule we've got a lot going on. We've got sodium, potassium, Atpase pumps that are sort of driving the through primary active and secondary active pumps. We are removing a lot of solutes like sodium and potassium and glucose and various other things out of the proximal convoluted tubule. Now, at this point, the proximal convoluted tubule is freely permeable to water. So water follows the solutes. So the osmolarity of the fluid here is equal to the osmolarity of plasma. So osmolarity of plasma here in the beginning, everywhere else in the bloodstream, the osmolarity of plasma, normal osmolarity, is about 300 microosms per liter. So the osmolarity here is 300 microosms per liter, and it stays that way because for every unit of electrolytes that are removed from the reabsorbed from the filtrate, a corresponding amount of water follows. So all the way through the proximal tubule, we keep a osmolarity of 300 microosms. Now things change in the loop of Henle. The loop of Henle is really where things start to get interesting. And the loop of Henle is the beginning of the story of the concentration of urine, which is interesting because it's actually very counterintuitive, and I'll tell you why. The osmolarity of urine when it enters the loop of Henle, as it enters the descending limb of the loop of Henle, is 300, but when it leaves the loop of Henle, it actually is hypotonic. So we're isotonic here at 300, but we are hypotonic at the end. So this was very difficult for me to understand when I first studied this topic, because people were telling me that the loop of Henle was responsible for the concentration of urine, yet when the filtrate leaves the loop of Henle, it's actually hypotonic. However, the loop of Henle sets the stage for the concentration of urine that occurs in the collecting duct. So the concentration of urine occurs down in the renal medulla as the urine passes through the collecting duct. And it's the loop of Henle that sets the stage for this. So how does that happen? Well, understanding the story, we really need to talk about the cuboidal epithelial cells in the thick ascending limb of the loop of Henle. And this starts down here, not far from the hairpin turn. So this here is called the hairpin turn of the loop of Henle, of course, and it's actually a lot closer together. If we were going to model this a little bit better, I would draw it more like this. Or even closer, but you get the picture. I just drew it wider so that I will be able to model this better for you. Now, so we have these cuboidal epithelial cells that are lining the tubule in the loop of Henle. Now, in the loop of Henle, I'm going to draw a bigger picture of these here. Magnify here. So we have the cuboidal cells, and I'm drawing little cilia at the apical border. So we have the apical border here, and the apical border is, of course, bordering the inside lumen of the tubule, right? So this is the lumen of the tubule, and then the basilar surface is actually lining the capillaries that have left the afferent arteriole. So we're talking about the capillaries right here. So we have a capillary that lines this tubule. Okay, so what's happening at the basilar surface? Well, you have a pretty good idea if you've watched my video about tubular reabsorption. But if you haven't, I'll just review it quickly here. What we have here is we have a collection of sodium and potassium pumps. And the sodium potassium pumps are, of course, pumping sodium into the cell. I'm sorry, I spoke wrong. They are pumping sodium out of the cell. 3 sodiums. And then they're pumping potassium into the cell. Right? So we keep our we are developing a concentration gradient, and this is a reaction that requires ATP. So this is the sodium potassium ATPase pump, right? So this requires energy, and it's reducing the concentration of sodium inside the cell, and it's increasing the concentration of sodium in the plasma of the vasa recta. Now again, the vasa recta is the term for the capillary bed surrounding the tubules. So we have a high concentration of sodium outside and a low concentration of sodium inside. Now also, in the tubule here, we have a high concentration of sodium that is pretty close to what we would see in plasma. Because remember, in the proximal loop of Henle, and this is going to change as I talk about in the discussion. This is actually going to increase over time, but we'll talk about that over time. But it's at least equal to plasma or greater. So it's 140 milliequivalents per liter or more, whereas in the cell it's 30 milliequivalents. And this is being maintained by this sodium potassium pump. So we have a very high concentration gradient that has a potential energy that is tending to push this sodium into the cell. So the body makes use of that potential energy by the use of cotransporters. So here we have the cotransporter that is really important here is a cotransporter called the sodium potassium chloride pump, or sodium potassium chloride cotransporter. So this is using the energy of the concentration gradient of sodium to pull in some potassium. So it pulls in 1 sodium, 1 potassium, and 2 chloride. So the net effect is we are removing sodium from the tubule. So you've got lots of sodium in the tubule here, and we are adding sodium to the vasa recta, right? So we're removing sodium, and we're adding the sodium here. Okay, so you get the picture. So the osmolarity, the concentration of sodium, here just ignore this now, as we move in this direction and pass these cells, the osmolarity is going to decrease. So it's going to decrease from, say, what was 300 microosms, and this is primarily because of the removal of sodium, to 200 microosms. Now, elsewhere in the tubules, in the proximal tubules for example, water would just follow along down along with the sodium, right? So we'd have water that follows here and then water that follows here. So it wouldn't change the osmolarity in the tubule or the vasa recta at all. However, in the ascending loop of Henle, the cell is impermeable to water, and that is why we have changes in the concentration. So we are decreasing the concentration of we are decreasing the osmolarity in the tubule, and we are increasing the osmolarity in the vasa recta. Okay? So now that we know that, we can tell the rest of the story. So what we have here is urine. It's not urine yet, but it's still filtrate. So filtrate is moving down here. And, for sake of argument, we're going to start out as all the urine in the loop of Henle is 300 microosms. So the osmolarity is 300. However, when it starts passing these cells, what's going to happen? Well, sodium is going to get pumped through these cells and into the vasa recta, right? So what's going to happen is, as the filtrate passes these cells, the osmolarity is going to drop in here. It may even get as low as 150. And at the same time, because the sodium is being pumped into the vasa recta, the osmolarity inside the vasa recta is going to increase from 300 to 400 or so, right? Now, what is important to understand is we have a countercurrent occurring here. And the countercurrent means we've got the filtrate running in this direction through the tubule. At the same time, the blood is running in this direction, the opposite direction, the counter direction, in the vasa recta. So what does that mean? Well, the vasa recta moves this concentrated urine over to here, right? Now, I told you the ascending limb is impermeable to water, but it's obviously permeable to electrolytes because of the sodium-potassium ATPase pump and the sodium-potassium chloride cotransporter. Now, the descending limb of the loop of Henle is not permeable to electrolytes, but it is permeable to water. So what happens is water goes down the concentration gradient, and what we have here is the concentration. Because water is getting pulled out of the tubule, this increases the concentration gradient here. So we end up with this getting increased. And the increased higher concentrated urine gets carried up into the loop of Henle, right? But then what we have here is the pumps are still happening. The pumps are still occurring here. So we end up, we started with 300 microosms, but now we're up to 400 microosms in the tubule, and it's still being concentrated, right? So now the 400 is concentrated to 600, and this 600 is carried down in the countercurrent through the vasa recta, and then we have further increase in the tubule, right? So now we've increased it to 600. Now, as water goes into the vasa recta, it doesn't dilute the vasa recta because the vasa recta has a current moving in the opposite direction. So, well, it does dilute the vasa recta, but here, let me show you. The diluted portion of the vasa recta is moving upstream and away from the hairpin turn. So you end up with, 500 here, 400 here, and by the time you get up to the top, you're up to 300. So the countercurrent is allowing this what's called a multiplier effect. So what we have here is now we've got a osmolarity of 600 moving in this direction, and this 600 is going to get multiplied further as the ion pumps continue, and we're going to end up with a even higher osmolarity. And this all continues until we get up to an osmolarity of about 1200. 12 or 1300. I've seen both. So we end up having very concentrated urine here near the hairpin turn. Okay, and again, it's able to be concentrated because this, as the water gets dumped into the vasa recta, that more diluted plasma gets carried away, right? So as we move in this direction, we get less and less concentrated. So what we end up here with is we end up here we have sort of the cutoff between the adrenal the renal cortex and the renal medulla. And if you sort of stuck a measurement device in to the kidney, you would realize that the osmolarity sort of changes as you move from through the layers of the kidney toward the more central parts of the medulla. So you end up with the interstitium of the cortex has an osmolarity of about 300 microosms, and as you move down towards the medulla, it gets higher and higher. And this is because of this countercurrent mechanism that's going on, right? Because this is all getting transferred to the interstitium. So the multiplier effect here creates what's called a hypertonic medullary interstitium. Okay, and this is made possible by the countercurrent of the loop of Henle and the vasa recta. So what happens is we've got our now hypotonic filtrate running down through the collecting duct, and as the collecting duct goes into the medulla, it's now up against this hypertonic medullary interstitium. So the body has two choices. It can either open up aquaporins, and aquaporins are just, they're little hollow protein pores that allow water to flow through, and they're actually sort of punched into they're actually placed, these little hollow tubules are quickly placed into the cell membrane of the collecting duct in response to antidiuretic hormone. So that's one choice. It can either insert these aquaporins in, or it can block them, or it can remove them. So what happens if you have the aquaporins present? Well, water is going to be pulled out down its concentration gradient from, its concentration of, it's starting to be about 150 microosms. And if we just pull water through, this area of the collecting duct is not permeable to solutes. So solutes can't get pulled back into the tubule, only water can be pulled out. So if we open up these aquaporins, lots and lots of water is going to be pulled out following its concentration gradient, so through osmosis, towards this very high concentration, 12 to 1300 microosms. And so this can result in urine that is as concentrated as about 1150 to 1200 microosms. Or if these aquaporins are closed because there is no antidiuretic hormone present, the body is not secreting it, then it could secrete urine that is as dilute as 150 microosms. Okay, so, and this is all directed by the antidiuretic hormone, which directs how many aquaporins are open in the membrane at any given time. Okay, so I did want to talk just a little bit about loop diuretics. This isn't a pharmacology course, but it's very interesting to think about how loop diuretics work. Loop diuretics work by actually blocking the sodium-potassium chloride pump. So what does that do? Well, let's think through it. If you block the sodium-potassium chloride pump, then you are not going to be able to concentrate, you're not going to be able to increase the osmolarity in the vasa recta. And if you can't increase the osmolarity in the vasa recta, then you're not going to be able to create this concentration at the hairpin turn of the loop of Henle. So you're not going to have a hypertonic medullary interstitium. So you will sort of lose the ability to concentrate urine, and you will end up excreting dilute urine. Okay, and interestingly enough, the other things that you excrete large numbers of relate directly to the sodium potassium chloride pump. You're going to tend to spill a lot of sodium, potassium, and chloride. And people who are given large quantities of Lasix can become hyponatremic, hypokalemic, and hypochloremic. And if you ever watch the lab values on someone that's on large amounts of Lasix in the hospital, usually we do a good job of repleting potassium, and sodium and water are sort of lost together. So sometimes the hyponatremia isn't very bad, but you will notice a very significant hypochloremia. Okay, and that brings me to an end of my discussion of the countercurrent mechanism for the concentration of urine. If you have any questions, please ask them in the comments below. I know this is can be a very confusing topic, and I hope that this was helpful for you. Please do provide me feedback as well, and if you want quick and easy access to my other renal physiology videos, then please click on one of the links below. Thank you very much. I'll see you in my other videos.